Good morning and welcome to our 10th annual Mid-Atlantic Telehealth Resource Center Summit. I'm Karen Ruban, Director of the University of Virginia Center for Telehealth. In addition to the massive scaling and adoption of telehealth our nation has experienced following the COVID-19 pandemic, our requisite virtual format has also enabled many more stakeholders to participate today. As of this morning, we have 587 participants from all across the Matrix region and beyond. We welcome each and every attendee. Much like the transformations we have witnessed in healthcare, our summit will likely remain a blend of in-person and virtual going forward. Kathy and I would like to thank each of our Matrix advisors for their insights and consulting expertise, our Matrix team members, our speakers, and of course, our sponsors for contributing to this program. You can find each on the website. We would particularly like to thank our star sponsor, VitalNet, and the generosity of Alan Izapana, and our platinum sponsors, Caregility, SciComm, and TytoCare. We'd also like to express our gratitude to our federal sponsor, the HRSA Office for the Advancement of Telehealth, led by Bill England and his team, Michelle Carnes, our program officer, Jenna Cope, our new program officer for Telehealth Network grant programs, Whitney Wiggins, program officer for the Evidence-Based Telehealth Network grants, Rhonda Jackson and Rob McKenna, Office of Regional Operations. Next, as always, it's a pleasure to introduce Kathy Wibberley, Executive Director of our Mid-Atlantic Telehealth Resource Center, who will truly kick off the program. Thank you so much.
Thank you, Karen. And it's a pleasure to be here. It's the very first summit we had. I was about 3 weeks on the job, and it's amazing that it's been 10 years. So one of the things that we have done is, as a telehealth resource center, we are one of 12 regional and 2 national telehealth resource centers funded by HRSA. We are joined this year by Great Plains Telehealth Resource Center as a partner in this event. We are also joined by our sister agency, SAMHSA, with the Danya Institute, which serves as both the prevention as well as the mental health technology, as well as the addictions technology transfer center. And so we welcome them, and this is our very first year doing a full telebehavioral health track for our summit. So it's pretty exciting for us to have these new partners on board. Next slide. I'm just going to do a really quick run of show for today, just so you know what to expect. Right now we are doing the opening keynote, and I will be introducing Dan shortly. From there, we will have a virtual break where we definitely welcome you to visit the exhibit hall and thank our sponsors, because we cannot possibly do anything like this without their involvement and their support. We also have virtual yoga going on with Amanda Baker, and Dan has agreed to stay with us for about half an hour after his presentation. So for those of you who want to come up to the stage, if we were in person, and visit and talk with and ask questions and just have that conversation with the speaker, we will be posting the Zoom room link after the presentation into the Event Mobi virtual platform, as well as in the chat box, and then you can join us at that point. Next slide. So in addition to 2 plenary sessions that will be broken out for our normal plenary as well as our telebehavioral health, after the lunch break, we will be having a luncheon plenary. And that luncheon plenary speaker is Chick Thompson, and you will be thrilled to have him. For those of you who remember, he shared with us about 5 or 6 years ago, and he is someone who will inspire you, who will make you laugh, make you cry, and make you feel all the things, but make you walk away really feeling excited about technology and about innovation and about being creative. We're also announcing our Breaking Barriers Through Telehealth Award after his presentation. And Chick has also agreed to stay with us in a Zoom room chat for those who want to chat with him after his presentation. Next slide. Followed by poster sessions. We definitely invite you to join our poster sessions. We have a great array of posters from all around our region and then some. We also invite you to, if you're interested in the correctional telehealth space, we are having a virtual happy hour, really looking at corrections telehealth and lessons learned, and having a essentially social networking session around that topic. So if that is of interest to you, we invite you to join. And then tomorrow morning, we will have our morning stretch, and we invite you to also join our welcome, because we will have announcements and things, and we definitely don't want you to miss that part. So next slide. It is our Matrix Summit tradition to not do long intros. We don't read bios. Your bios are in your virtual event platform, and you can read those. So with that said, I am going to really quickly introduce Dan. Dan Weberg is someone that I have met, I think about 7 or 8 years ago now. He has been a great part of our summit, has always been willing to say yes, and today had said yes to doing this while being on the West Coast. So it is, 6 o'clock in the morning for him. I just want to say thank you to Dan for just being an innovator, for being a leader in this space. And without further ado, if you have questions, put them in the Q&A box, and I will punt to Dan.
Awesome. Thanks, Kathy. And hi, everyone from the West Coast. It's still dark here, but it's going to be 80 today, so I can't complain. I'm excited to be here today and chat with you about disruptive innovation, what's hitting the healthcare industry, and how we might actually build teams to be more adaptive as more new entrants come in, more disruption is in our future. And we'll chat about all that today. And really, this is from a viewpoint over the last year or so in my role at Trusted Health, which is a technology platform for healthcare workforce. I got to see across 5,000 facilities, all 50 states, just how everyone adapted to COVID. But even before that, how the workforce is changing and adapting. And so hopefully bring those insights to you so that you can learn and lead your teams to the disrupted future that we're all going to experience. So the first question the first question we have to ask ourselves is, are we in chaos? And when I show this, usually people are like, yeah, I'm in chaos. I'm scattered all over the place. I don't know what's happening next. Like, but if you look at complex adaptive systems, chaos has a different kind of frame of reference. And so in complex systems, chaos is simply the inability to predict outcomes. And yeah, we're in chaos. We don't know day to day what those outcomes are, but we can see patterns. And so in complex systems, when systems are in chaos, you may not be able to predict the moment to moment changes, but you can see the patterns over time. And so today we're going to be taking that chaos lens and looking at the patterns. Now, we may not know all of the direct correlations and causations of the impact of some of the things that I'll talk about, but we can sort of predict the patterns and make educated guesses on where things will go. And then that will help us be ahead of the puck, basically skate to where the puck is going to be. And so we'll keep that frame of reference as we move forward today. So, one of the first patterns that's happening in healthcare is it's becoming more and more fragmented. I think we all hope that with electronic medical records and things that we'd actually get to be more systemized. But with the apps, the data silos, professions sort of insulating, disruptions to the market, and we'll talk about that more. And even just through the last year, professionals, especially nursing, being treated more as a warm body to fill an empty slot rather than, the professionals that we are. It just fragmenting the system a little bit more. And every time a new digital health solution comes out, it's one more place someone has to go to enter their data, to interact with somebody else that, without porting that data back into some central place where everyone can see it. And so we do have a lot of fragmentation. And when you work in a fragmented system, there's some poor outcomes for teams, and we'll talk about that too. But let's dive right into some of the COVID examples. So again, my view at Trusted Health as the nurse leader there is to kind of see the workforce trends across all 5,000 plus healthcare facilities that we work with across the country. And these are some of the things that we saw. The first one was, just this really big, a poor ability to forecast needs. So all the way from the first spike in New York, where the state was calling for 10,000 nurses. Our company was able to get 200 nurses on planes overnight, on the ground 2 or 3 days after the request. And we saw about 30% of those nurses canceled when they showed up for the first day of work. And so what happened is hospitals oversubscribed for the demand, and our nurses were kind of sent home after they had jumped on airplanes to go help this call for help. So and that just continued throughout the entire pandemic, and even before that, just hospital systems, clinics, health systems just don't have a good way of predicting supply and demand of workforce, and so that directly impacts clinicians and leads to a lot of burnout and other issues related to that. We see a lot of dysfunction in onboarding, and this is upwards of 40 hours of online modules that specifically nurses have to click through in order to work at a health system, even though they have 15 to 20 years of experience at the top academic medical centers in the world. When they go to their next assignment, they're still made to do prophecy exams so that we can say they're competent. And so we just have a big dysfunction in how we assess healthcare expertise and competence, and how we use kind of best judgment to onboard clinicians into new systems quickly. We did see a lot of clinicians treated like commodities. We have a saying in the industry called 2 feet in a heartbeat. And so a lot of hospitals wanted 2 feet in a heartbeat when really there's a lot of nuance to the clinical expertise, which And so one of the things that I'm very passionate about is how do we actually match the skills, passions, desires, clinical competence of our clinicians to the right role at the right time, and ultimately to the right patient. And so there's just a lot of room for improvement there. We saw kind of this this scramble to get people kind of that 2 feet in a heartbeat mindset, where new graduate nurses right out of school were put into COVID jobs in ICUs, which, as you can imagine, isn't the safest thing to do. It's risky to the patients and the clinician both. But we did see that, and again, that goes back to that supply and demand problem. Lack of PPE, we heard enough about that. But we also saw some weird leadership emerge as well. And we had a number of nurses that would bring up safety issues related to different things, whether it was PPE or patient care or whatever it was, or even just how the system was being run. And they'd be fired on the spot. And this is mainly travel nurses that we deal with, but we saw that. And it just questions, in crisis, in chaos, you fall back to what and there was definitely a gap in leadership that we saw across systems as well. So not all this to be doom and gloom. It's just there's a lot of room for improvement. And if you look at innovation literature, markets innovate when there's cracks in the sidewalk. And so these cracks in the sidewalk were always there. They're just widened as COVID came through and kind of grew that, kind of the earthquake, it made those cracks wider and wider. And so it just provides us a huge opportunity for us to do better, to leverage technology and telehealth and all sorts of different ways to innovate because the market needs it. And we see that in the consumer demand. And so we know that the consumer is demanding better. They want effective, on-time, and cost-effective care, and that's always been there too. But again, this is going to be more and more the trend as we move out of the pandemic. So what happens though is if we have teams that have all these issues kind of going on and fragmented systems, there's a fair amount of research that says that the teams will actually burn out if those systems aren't fixed. And there's been a lot of a press around burnout of physicians and nurses lately, and it's just going to get worse if we don't fix the cracks in the system. And so this is from a research paper that I did, an evidence-based practice paper I did in 2009 even, but it's still true today, which is the outcomes of healthcare teams in fragmented systems are burnout, turnover, failed onboardings, bad workarounds. Now there's good workarounds, but these are the bad ones. Cost, wasted time, and eventually toxic teams. And we'll talk about toxic teams a little bit. So it's not enough to just Band-Aid over these things. We have to actually fundamentally fix the system, or our healthcare teams are going to be burned out quite quickly, according to the evidence. So to answer the question, are we in chaos? Yeah, we're in chaos. So let's go through a couple examples of some of the clashes that are happening, some of the patterns we're seeing in the system, specifically in health systems, and then talk about how we might lead our way out of it. So there's a few culture clashes specifically, I think, interesting for this group that give us some patterns that we may need to think differently about. So the first one is we still have policies in really quote unquote innovative health systems that are restricting access to information, and usually this comes to fruition as the lack of use of mobile devices within the clinical setting. And so this is specifically, nurses specifically have a hard time with this. There's policies in hospitals and health systems still that don't allow nurses and frontline clinicians to use their devices in clinical settings. And the rationale when I talk to leaders about this, well, we don't want them to FaceTime, or we don't want them to be on email when they should be, doing XYZ. But what you're actually doing is you're restricting access to information. And we all know care is so complex that you can't memorize it all. You can't have it in a book. You can't reference it in the drug book you have in your white coat. You have to have a digital solution to be able to access this. And the computer systems we have, it's still 15 clicks to get in and look up one drug when you could ask Siri about it on your mobile device. So we have to really think about the demand of our clinicians coming into work from school is that they are connected to some device at all times. And if we have policies that are restricting that access to real-time information, we're not only hurting patient care, but we're going to lose out on the best clinicians because they're not going to put up with a system that still has archaic policies around that. The next thing is our training methods are not matching our practice environment. So I talked a little bit about the onboarding piece. And 40 hours of click-through modules where you can find the answers to the tests online, and we call that, well, they clicked through it, now they did that ICU exam, now they can come work for us, they're safe. It's just not the right way to do it. And so what we're seeing is completely new training methods happening within nursing schools and medical schools. And so one of my roles is founding faculty at the Kaiser Permanente School of Medicine in Pasadena. And we made the decision early on to be a cadaverless medical school. And we did it because there's a fair amount of evidence coming out that virtual reality training actually speeds up the learning for students with the same outcomes as if they worked with cadavers. A Case Western study in the past couple of years showed that you could teach the same anatomy class using virtual reality 6 hours faster than you could with cadavers. It takes about 9 hours to teach a cadaver class around this certain system, and it took about 3 hours in virtual reality. The students got the same or better test scores in the virtual reality group. And I just imagine as a faculty member, like if I had 6 hours per body system back into my curriculum, what else I could teach: interprofessional education, leadership skills, some of the other clinical foundations that we kind of gloss over because we have to do it old ways. And our clinicians are getting trained like that in school, and now they come into health systems where their annual education day is on poster boards and printer paper, and it's just not matching. And so we have an opportunity to really update how we continue to train clinicians, expose them to things, and actually give them sort of superpowers as we leverage these new training environments. And then the last kind of trend that I'll talk about is this workforce trend. And so there's a definite move, especially within nursing, to a more flexible, mobile, and not tied to a pension kind of mindset in the workforce. And so, nurses are coming in to get 1 or 2 years of experience at really well-established organizations, and then they want to go hit the road. Number one, because pay is better, but number two, because they don't want to be tied to a system necessarily. And so there's a lot of things that health systems need to do to prepare for a more flexible workforce. Going back to that supply and demand side equation, there's some things that we can do and think differently about what our workforce is. Before it was, how long can we retain you? We want to keep you here for 30 years. It may not be like that anymore. And so how do we rethink engaging our workforce, providing benefits that are maybe different than what we thought about before, and thinking of retention as one piece of it, but how do we get the mix of full-time support or full-time employees, and then a seasonal or flexible labor pool that actually comes in and out more frequently with us? And maybe that's the model moving forward. So all this to say, this is the sign you've been looking for. This is the change that's happening, and it's good. We, as innovators, and I know most of you in the audience are innovators, or you wouldn't be here. This is the chance for us to really solve some big problems, especially because COVID took away a lot of bureaucracy, and so now there's no going backwards. And that's the best place to be as an innovator. You know, when we had electronic medical records enter into the systems, we had to literally take the paper off the unit so that you wouldn't use it anymore. And now we have that. The paper's been taken away. There's only forward, and especially for telehealth, there's just a great opportunity to just blow forward with this. And there's a lot of constraints. So, right, there's policy and regulation and all these things that are here, but constraints breed innovation. So if you think of a box, people always say, think outside the box, but innovation happens in constraints in a box. And what those constraints do is it actually harnesses and focuses the energy of your efforts much more than if you had just blue sky kind of open brainstorm thinking, which doesn't have constraints. And those constraints help us make more relevant ideas, and also allow them to be adopted faster because they're tied to the operational issues and things that are happening within systems. So embrace constraints. And as a healthcare and innovation leader, you should actually be creating constraints for your teams so that they can innovate within the box, so that their solutions are actually implementable moving forward. And so we have some new entrants that are disrupting the system. And I don't know if you've heard of any of these guys, but I think it was last Monday, Amazon launched officially their Amazon Care platform. And I think that's the most interesting one out of all of them. I mean, I have this dream that one day you log on to your Prime account, you see a virtual nurse practitioner, they send you a mail lab kit through Prime delivery. It gets there in 24 hours. You do a couple lab tests, it results right there on your phone, and you get diagnosed with diabetes. And then Amazon uses its entire supply chain to uses Whole Foods to send you diabetic healthy diets. It sends your testing kits through its pill pack and supply chain network, and your insulin and or pills are sent as well, and it all arrives there to your doorstep within 24 hours of that virtual visit. And I don't know if there's a health system on the planet that does that yet. And so it's really interesting to see how they can leverage their supply chain and network of consumer goods to actually improve care potentially. Whether you love Amazon or hate Amazon, there's a great potential there. The next one is Google. So Google has over 500 employees in their health division. And you know, they're all about big data, and many of you may have partnered with Google. They're creating more and more partnerships. But the thing about Google is they're not afraid to fail, and they've had a couple big ones, data security and privacy things, but they're not afraid to push the walls there. And so it'll be interesting to see how Google leverages its kind of network and knowledge to disrupt healthcare. It's a lot in life sciences right now, but you know, there's opportunity to really link the world's knowledge together more seamlessly, and potentially provide it to clinicians in real time much faster than some of the vendors out there now. Apple's, you know, their privacy and device company, and so I think their watch is where they're really doubling down, and so we'll see more and more if that becomes the medical device of the future and takes all your vital signs instead of just diagnosing you with AFib. And you know, there's an opportunity there to have a wearable device on a lot of the public, and you know, the question then becomes, what do we do with all this data? And you know, we had this conversation, I don't know, 7 years ago when I was at Kaiser Permanente, and it was just really interesting. You know, people were like, "Oh, we'll send it to the primary care physician. Yeah, they'll want to see all their panels' blood pressures in real time." I'm like, no, they don't. They're not going to look at that. So there's an opportunity for us to think about, what are the roles of the future? What do we do with all this data? If we can see 18,000 blood pressures, you know, in a given 8-hour period because of these wearables, you know, what do we do with that? And what do we know and don't, you know, not know about physiology related to those things? So that'll be interesting as Apple comes through. And then Walmart and others are creating their care clinics, right? So they, you know, you have a Walmart within 40 miles of every human in the United States. And you know, they have a massive network to disrupt primary care potentially. And so more and more of that's coming out. And so just to say that, there's non-healthcare people that can innovate much faster than our healthcare system can, entering the market and are going to be really disruptive. And, I think we need to think of it as potentially partnerships or, speed up our systems to adapt quicker. So let's look at sort of 3 disruption sources within our own industry, within healthcare, and some of the trends that are happening there and what they might mean for us moving forward into this disrupted new future post-pandemic. So we'll talk about education and how learning science has shifted, and I'll give an example from the Kaiser Permanente School of Medicine. We'll go a little bit more into the workforce piece, and then we'll talk about some of the technologies that are disrupting our system as well. So with education, it's been really interesting. I started off as one of 30 people and the only nurse on the team building the med school at Kaiser Permanente, and we had some crazy talks about why even admit people unless they've passed their step 1 boards, because you can pass it. It's a standardized test. If you study for it, you can pass it, and then maybe medical school starts. So we had just interesting conversations with that. But ultimately, we landed on just a different way of adopting learning science into the curriculum. So the building was actually built with 0 lecture halls. There's no lecture hall in the entire building. There's no chalkboards. You can't have chalk talks or sage on the stage. Those were brought up a lot in the building of the school. We really doubled down on the interleaved slow drip learning. So if you're familiar with the company Osmosis, it's what they do. So they give you small snippets of information and they slow drip questions, board style questions to you over time. They take that information and feed it back to you around your weaknesses as far as knowledge goes until you can kind of speed it up. So instead of just a chunk of information and saying, hey, we did cardiac system for 3 months, you should know everything about it, and then never touching on it again, really kind of interweaving all this curriculum together. So much so that there are only 3 classes in the entire med school throughout the 4 years. There's foundational science, clinical science, and health system science, and all of them are interwoven. So on Monday you may have all 3 classes, and on Tuesday you might have all 3 classes, but you never know which class you're in because the content is all woven together, kind of baked around a case. And we slow drip this information, so we may kind of highlight the renal system for a couple weeks, and then we move into the cardiac system. But when we move into the cardiac system, we're already pulling through the threads from the renal system. So really weaving this content together instead of blocking it out like traditional medical school was. The other piece is it's all active team-based learning when the students are on campus. And so that's something that I think is kind of interesting. So there's no lecture when they're on campus. All the lecture kind of content delivery, passive content delivery happens while they're at home or online. And when they're in classroom, they are in small groups with facilitators doing active team-based learning. Which has been going really well. Even when we did interprofessional education, so we partnered with USC School of Pharmacy and Western University of Health Sciences nursing program. Still small group facilitated learning, even online. We use Zoom now for that, and it's been amazing to see the students really take charge and engage in that active learning style. And then it's technology enabled. So I said it's cadaverless. We have the virtual reality as the way we're teaching anatomy, along with some plastinated models. And so really making technology as a core. And we know students are on SketchyMed and Osmosis and all the different things while they're in class. So we made those tools part of the curriculum so that the students don't have a hidden curriculum behind the scenes where they show up to lecture and have their face there so they can get credit for it. They're actually engaged in the things that they would be doing anyway. And then it's fully integrated. So integrated testing, integrated curriculum, and it's just really interesting to see. It's very different from the faculty freedom. You can create your own course in your silo method, but these are the trends in the science that's coming out around learning. And so, how do we take these things and embed them into our schools and our training programs within health systems? The other piece is there's a ton of content out there, and so why is nursing or medical school in Texas writing another PowerPoint about the anatomy and pathophysiology of the heart? It's been done for 2 billion years. And it's out there on YouTube. And so why are we having faculty continue to write, content that's already out in the public? And instead, faculty should be providing context, not content. And so we can leverage content that's out there that's really well done, and the faculty's job is to facilitate the learning around it rather than creating the PowerPoint and being that content expert. And so what does all this mean? This one I think will be interesting to this group, which is, there's really not a whole lot of schools out there that are teaching telehealth skills within the foundations of their curriculum. I know that to be very true across nursing. And when we did an assessment of medical schools, it was this isn't part of the core curriculum. But what if you just took a second and thought about how you learned health assessment in whatever clinical program you may have come from? And we learned it by practicing, reading about it, and then practicing on each other, maybe a mannequin, maybe a few patients out in the wild, and that's how we learn cardiac assessment. But what if you actually structured your curriculum to do it to enhance across all modalities that we now can assess and interact with patients? So first, we need to have the physical touch, and that's the core still of practice. But what if you took that then and went into the next room and you did that cardiac assessment using video with only a visual and audio cues? And then you went into the next room and you had to do it through telephone. And then you went in the next room and you actually had to do a mock email exchange between the patient. And you went in the next room and you had to do it through text and texting images and shorthand back and forth. And that's how you learned health assessment all the way through. Now you would have clinicians that are able to come into systems, clinics, settings, and feel comfortable with the information they could gain from each one of those, instead of coming in and having to hack through it, or maybe just falling back on that, well, I don't have the physical information, you got to come in even though we did a video visit sort of thing. If we could really teach these skills as the foundation of undergraduate medical education, undergraduate nursing education, nurse practitioner programs, et cetera, we could really change the game of the workforce, give them skills to adapt quickly as these technologies continue to enhance our practice in every setting, including inpatient, outpatient, and everything in between. So let's talk about the disruptions in the workforce as well. So the workforce is changing. I mentioned that a little bit. There's a move to have more flexibility in work, and maybe not staying at a system for 30 years and collecting a pension. Pensions are going away, and so there's a group of clinicians that are coming into the workforce saying, I think I want something different than that, and I want to move around, and I want to see the country. And it'll be really interesting to see how that continues to disrupt the kind of ideas that health systems have. But there's a few kind of big trends here. So one of the things I like to say is you will never, ever, 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 ever be fully staffed ever again. It just won't happen. I don't think you were before the pandemic, and you certainly won't be after the pandemic. And so we have to just rethink what we think fully staffed is. And in this context, usually it's I have enough full-time employees to staff my, you name it. But that's never really been true, and there's an opportunity for us to rethink it. So, what's the balance? What's the right balance between core staff that are on your teams, and then flexibility in labor that comes in and out, whether it's clinical labor or other. And so we think we just have to rethink what it means to be fully staffed. We also need to move towards skill determining assignments. And the past way that we've kind of done this in healthcare systems is, well, we have, let's say, 100 nurses on an ICU unit, hired into an ICU unit at any given time. And we hope that those 15 that are on shift tonight are the right skill set and the right competencies to take care of the patients that are here tonight. And it's kind of this random thing, like, we've classified people as their specialty rather than their competence in certain things. And I think as we get more technology, as we get more flexible workforce coming in, we'll get better at taking specific skill sets and matching them directly to patient needs, instead of kind of these broader buckets that we have. And imagine if you could have that right clinician at the right time, at the right patient, matched with technology and competence, you could really maybe change the game as far as patient care goes. We'll have this on-demand workforce. This has already started. There's several organizations out there that have started on-demand workforces, shift gap filling, especially in the long-term care space. And it's kind of the Uberization of some of this model. Now, there's definitely downsides to that. The kind of frequent in and out of clinicians isn't always best for patient continuity and things. But I think as we get better at onboarding, at competence assessment, we will have an ability to actually Uberize some of the clinical workforce in order to meet the needs of patients in any given moment. And then the last piece is just we don't have data that, I'll speak specifically about the nursing world. There's a really big gap in data about the nursing workforce in any specificity. So we may know how many nurses there are in the country, but any given state doesn't know how many nurses they have currently, how many of those are working, what specialty, what competence they have. And so we're really flying blind. And what that results in is kind of what we saw with the pandemic and kind of travel and travel nursing, which was bill rates and things got skyrocketed because that was the only lever we had. We had no idea how many nurses were in our geographic area that we could even tap into or how to tap into them. And so the only way to attract talent into the system when we really needed it was to pay more. And that's a very simple lever. And there's just better ways to do it. If we had more data, if we had a kind of system of record for clinical talent, we could potentially better optimize the supply and demand equation there. And just some numbers from a nursing standpoint. I mean, there's about an 8% vacancy rate for nurses across the country. It's estimated there's 175,000 jobs open every year from now until 2030. And we only graduate about 120,000 nurses from nursing schools every year. So there's a huge gap. And that gap is one of those cracks in the road we talked about. And somebody's going to fill it, whether it's nursing or some other profession is going to have to fill that gap because patients need care. And so the workforce piece is a huge driver for innovation. It takes about 70 days to fill an open nursing position. And every day, about 10,000 nurses turn 65. So there's a kind of retirement cliff that has been pending over nursing for a long time, and we're starting to see that happen. But what does the future of healthcare workforce look like? So this is some of the positive things. So flexible work. So I think, hours, location, settings, can we move away from 12-hour shifts and have more flexibility in start times and those type of things? I think all of that is up for grabs. The skills match to need we talked to. What if you didn't have service lines? What if you just had patients and you matched the right clinician to the right time, regardless of what unit that person's on? And then the practitioner is becoming increasingly in control because there's such a shortage in both physicians and nurses and pretty much every healthcare profession. The practitioners can kind of demand where they want to go and get it. And so I think we're going to see more and more control move to the workforce from systems, and systems are going to have to innovate what their packages are to retain and attract top talent into their systems. Then the last thing we'll talk about here is really the technology is changing. So just like we talked about, the training methods around telehealth aren't embedded in schools. Machine generated insights training is not embedded in education as well. And so this is, how do you as a clinician trust the machine to give you the data and insights that you need to make a clinical decision? And we've kind of had to learn it on our own, but we need to start embedding this early on in the curriculum. So what happens is, let's take the modified early warning score that ICUs use to predict if a patient is going to get sicker and need higher levels of care. So that Muse score is made up of very tangible things that you can touch and feel, vital signs, some assessments. You can actually look at the patient and do the assessment. But at Kaiser Permanente, there's a research going on around something called the Advanced Alert Monitoring System, and it's able to predict the early kind of demise of patients hours and hours before it would even show up on vital signs or a clinician could recognize it. But clinicians don't trust it because it takes hundreds of data points rather than the 5 data points from the Muse score. And so we have to just start thinking about how do we assess that the scoring or the algorithm behind the insights are actually trustworthy, and how do we know when to incorporate them, or even how to incorporate them into our clinical decision making? And right now there's kind of a dichotomy. There's you either blindly trust the machine because you do. You kind of know something about the algorithm, and so you're saying, hey, yes, I believe that that number or that score is trustworthy, and I can make a decision off it. Or you don't trust the machine at all, and potentially, delaying decision making around whatever it is. So we just have to get better at incorporating those kind of trainings into our clinical workflows. The next piece is data is becoming more portable across old boundaries. And so I know we're all excited about interoperability, and we have been talking about it for 10 years now. And I don't think we're interoperable yet, but there's different organizations that have solved some of this. So there's a company called Seqster, Seqster, that has built basically the mint.com of health data. And they're able to seamlessly integrate wearable data, genomics data, and electronic medical data into your health dashboard, basically. And right now, companies are using it for clinical trials. So people that are enrolling in clinical trials, it used to take weeks, even months, to get faxes of these patients' medical records and things into the clinical trial so that they could do the research. Now, with a click of a button, they can integrate that data within seconds. And so we're going to see more and more data port across the boundaries. And eventually, my prediction is that the patient, and maybe Epic will do this, they'll put out a patient-facing app that now the patient owns their data and can take it wherever they want. And so now they're not tied to a certain health system; they own their own data, which will be really interesting. We'll see if Judy pulls that off. And then the last piece is there's just massive data sets, which we talked about. There's tons of information flowing at us at any given minute. And we're all trying to individually process all this stuff. But I think there's an opportunity for us to create new roles and new departments that are clearly focused on health data and parsing through the massive 18,000 blood pressures you can now get from the Oura Ring at any given moment. So all that to say, disruption's here, and that's great. So let's embrace the burning newspaper, and let's now talk about how, as a team, as a leader, we can move forward and bring our teams along this path of disruption and change. So the first rule that we'll talk about is, as an innovation leader, you don't need to be an innovator to lead innovation. And so I think this is a misconception that a lot of leaders take is, I'm not creative, I don't have the ideas. That's fine. If you're leading a team, you don't have to have the ideas. You can lead innovation by creating the box, the container, the constraints that drive innovation. And your job is to make the connections, not the ideas. And so if you think you can't lead innovation because you're not creative, that's no longer an excuse. And there's a couple places where we can focus our innovation efforts. And so the first one is you can lead a change initiative. That's the easiest low-hanging fruit one. But I think we kind of miss where we can innovate other places. We always think about technology and what can we disrupt in our own practice or within our health system. But we can also be innovative in our professional growth. We can find new training methods, disrupt the paper training annual education days. We can innovate in our own profession, advancing scope of practices and changing the way our profession actually meets and discusses things or gets access to information. And we can enhance our practice individually. How can we get better and change things? So as professionals, we have lots of options to lead innovation. It doesn't always have to be that technology in our system or in our clinics. And there's a couple innovation competencies that we have to really think about. So the first one is, and I think this one we miss a lot, is we have to train ourselves differently in leading change. And there's a lot of science out there about how change occurs in populations, everything from diffusion of innovation to complexity systems to business literature around how organizations have adapted over time. But a lot of times we kind of forget all that. We go straight to the Six Sigma piece, which definitely has evidence as well. But there's a lot of research in how populations experience change and adopt change that we just kind of gloss over. And instead, we think we have some magical way of doing it, or we do kind of a top-down approach to it that has been proven many times not to work in situations. So I think we need to go back to our evidence-based roots and start evidence-basing our change leadership. The second piece is accountability, and we'll talk a little bit more about this when we get into patient change, but there's a lot of accountability or there's a lot of issues with bad leaders. And so bad leaders can actually kill teams and kill organizations. And so we have to start holding people accountable for being not so great leaders. We'll talk about that in a second. And then we need to just value innovation. I think healthcare in general puts a lot of value on performance improvement, but we'll talk about why you might need to put a little bit more value into innovation and that disruptive change. And just remember, leaders are the key to innovation, and there's some evidence behind that. So innovation is directly impacted by leaders, and it's also directly disimpacted by leaders. And so there was a study done by Dr. Bern Melnick, who's the dean of the Ohio State University College of Nursing, looking at the adoption of evidence-based practice in health systems. And she found that the number one barrier to the adoption of change in health systems is not the nurses, is not the physician, is not administration or the finance guy. It really was the frontline nurse managers. And this is simply because they're not set up to adopt change, or they're not rewarded for adopting change. They're rewarded for maintaining the status quo, keeping the ship running, making sure they're staffed. And that ends up setting them up to stop any adoption of new things, not at their own fault. And so we just have to think about that. If the front line, so ideas coming from the care settings themselves are blocked on the first reporting line in the hierarchy, that's an issue. And so as we look at systems, how do we set up leaders for success and incent them to actually help shepherd change through rather than stopping it before it ever gets to anyone else's ears? Team interaction is also able to predict innovation ability. There's some work by a guy named Losada who looks at high performing teams, and he found in one of his studies that simply by the way you talk to each other in an innovation setting can predict if your team's high performing or low performing. And so he found this, teams that, and it wasn't they were all positive and Pollyanna. It was the teams that were able to constructively challenge each other's ideas, build upon those things, and have those kind of crucial conversations were the ones that were innovative simply by just looking at the way they talk to each other. They could they could see if they could tell if it's a high performing team. The low performing teams were the ones that just spiraled in on each other. So someone had an idea, oh, we did this 10 years ago. Oh, that's never going to work. Those are the teams that really got low performing. Excuse me. Innovation is not evidence-based usually. And so that's something that we'll talk about in a second. And then innovation is just misunderstood in health systems. So, the top focus areas for chief nurses specifically would be quality and safety. Yet, when you ask them where they ranked evidence-based practice, change, and innovation, it was down at the bottom of their priority list. And so there's a disconnect between evidence-based practice and change and its impact on safety and quality. And so we have to just flip that in our systems as well. And ultimately, a high-performing team uses what I call evidence-based innovation. And so this was the foundation of our book, Leadership for Evidence-Based Innovation. But basically, high-performing systems have two competencies. The first competency is they have performance improvement competency. So they're able to take what they know and optimize it. And the other competency they have is innovation competency, which is bringing in or creating new ideas and kind of those disruptions from the status quo and bringing those into the system. Now, what usually happens in health systems is that we focus a lot on performance improvement. We kind of push innovation over to the side. Performance improvement lives under the quality team. We're very focused. We get everyone Six Sigma trained. And then we make this little innovation team that lives over here in the cool window office under maybe the strategy person or over some random team that's really disconnected from the core piece of the business. And if you separate those two teams, you're actually you're not a high performer. You can't just have these two teams living in your organization. You actually have to integrate them. And the reason is high performing systems are able to bring in new ideas as the market demands and optimize them to move them forward. And so if you just have performance improvement, you're only going to be good at what you know. You're going to just be able to optimize your systems to a point where they're as efficient as possible. But if the market demand changes, the environment changes, you may not be equipped to change very quickly or be disruptive outside of that. If you just have innovation, you're going to bring in a lot of new ideas, but you're not going to be that efficient. And so you have to have both. You have to bring in those new ideas, make them efficient, and embed innovation and performance improvement together. Now, this isn't very easy because these teams usually don't like each other. They have very different philosophies of the world. And so it takes a long, strong leadership to be able to embed these together. And part of this is just creating a framework for change. And so what happens in health systems normally is we spend about 25% of our change efforts using performance improvement, about 5% of our change efforts using what we call innovation, which is usually post-it noting. And then we spend about 70% of our change efforts just throwing stuff at a wall and seeing what sticks, whether that's my opinion of how change should happen or whatever it is, just literally throwing post-it notes and dots at a wall. We have to start using the evidence to change, to create our change processes, because there's a lot out there. And just so you know, this is not innovation. And many of you joined us yesterday for the design thinking workshop. And we use post-it notes, virtual post-it notes and dots. And not to say that post-it notes and dots don't have a place in innovation, but it's not the only way to innovate. And what I see a lot of health systems do is they have a nice pizza party and they have a lot of people in a room and they pick a really hard problem and they spend 8 hours in pizza and soda and a lot of post-it notes brainstorming about that. Then they lump and clump and they put them, they organize them, they draw circles around them. Everyone gets 3 dots because 3 is the evidence-based number of dots that you should use to vote on any hard idea in innovation. And then you take pictures of those ideas because you've narrowed it down to 3 or 5 or whatever arbitrary number you have. And then those go into your phone or into the leader's phone. And then they never surface again. They are stuck in that phone. You have now innovated a picture onto your iPhone. And usually these days end with, well, we're going to take this back to the leadership team and present them and we'll see what happens. And now you've wasted people's 8-hour day. You think you've been innovative and everyone goes home like, oh, that was a waste. We spent all this time and effort to get a picture taken. So I think we have to just rethink our way of innovation. Innovation's a longer process. There's as much rigor to innovation process and design thinking as there is in Six Sigma process and lean. And so we just have to really rethink how we are doing this work, and design thinking tools are one possibility there. And we have to start challenging our assumptions. So as leaders of innovation, we have to really look inward first. And there's a couple ways we can do that. First one is, it's about what's best for the outcome, not the ego. And a lot of times, and especially in that Losada article, the ego was what got in the way of low performing teams. It was about my idea, or I know best, or I'm the expert, or I've done this for 100 years, so I know what's best for things. And as soon as teams let that go, they trended more towards high and medium performing. The other piece we just talked about, go beyond the post-it notes. You got to have tough conversations. At Kaiser Permanente, we spent a lot of time. We called it the Core 5, and it was 5 of the kind of middle leaders of innovation and performance improvement that tried to make the teams mesh together. And it took some hard conversations because there's 2 very strong ideologies in those teams, innovation and performance improvement. We had to bring them together, and it took a couple beers. It took the side conversations. It took frustration, and so you got to kind of work through those dynamics in order to create a team that is able to change moving forward. Your idea is usually not the best, and so let go of that. Once the idea is out in the wild, let it flourish. And then finally, demonstrate your innovation behaviors with your faculty, in the case of education, but also in your facility. And so you have to have that risk tolerance and be able to push through some of the issues so that the team sees what's happening moving forward. And let's double down on tackling that hard stuff. So this is an example of an innovation project we did at the med school. And so one of the things we wanted to do is just do interprofessional education differently. And we knew that most interprofessional education in the country has been done on paper with case studies and sitting, med students and nursing students and physical therapy students together in a room and saying, hey, go solve this thing, or hey, go into this code and work as a team together. And then we check the box, oh, we did interprofessional education. But we wanted to dive a little bit deeper, and we wanted to address the underlying biases and assumptions that happen between professions on teams in the real world. And so we actually brought in our interprofessional partners, and we talked about all this stuff. What are the power dynamics between professions? What are the assumptions that students have about other professions? So we even talked about doing a skit where the med students did a skit about what they thought nursing students do, and the nursing students did it about pharmacy students, the pharmacy did it about nursing students, and really just on day one, get out those assumptions of what do you think this profession, these other professions are and do. And we didn't do the skit piece, but we did have the conversation about it, and just fascinating what the bias and assumptions are underlying this. And if we don't address it quickly, then of course it moves throughout the entire life cycle of that student, and then into their professional practice and into residency and other places where it just gets further entrenched in their work. So there's just a lot of opportunity there. Scope of practice overlap and all these things as well. And so we tackled those things, and we came up with a really awesome model of addressing each one of these things, so that the students didn't learn any clinical together. There was zero clinical kind of learning within the first 2 years. It's all about how teams interact. And we just finished the first year of the curriculum, and the students gave us really, really good feedback, and we're actually seeing behavior change because we tackled the hard stuff first. And ultimately, your work as an innovator, innovation leader, is to remove barriers. And so you do that by tackling the hard stuff, having those difficult conversations, setting the constraints, building the pieces that allow for teams to have fluid and real conversations moving forward. And if we don't do that, then we will be stuck in the status quo, and we'll see the Amazons, Googles, and Walmarts overtake our health system very quickly, in ways that may not be as good as if we were able to innovate with them or alongside. And then we got to talk about the hard stuff, right? So there's definitely the other side of the fence of innovation leadership, which is the toxic leadership. And toxic leadership are those leaders that really don't create connections, don't allow change, make people feel really horribly all the time, but we tolerate it because they're the expert in their field, or they drive X amount of revenue or whatever. But we have to start bringing light to this, because if we're going to change the system, we have to get rid of people that stop that change, whether they're laggards or whether they're toxic. And there's just some real numbers behind this. So I've personally experienced toxic leadership. I wrote a whole chapter in our book about it. It's chapter 13, which is kind of funny. But when you have a toxic leader, 12% of the people quit, 63% lose time avoiding that toxic leader, 48% decrease their work effort, and 78% report decreased organizational commitment. So that's like, I don't know, 200 and something percent of badness that happens if you have toxic leaders. And on the innovation side, they completely stop anyone from changing or brainstorming around ways that could be better, and create a power dynamic where they're the gatekeeper for all of this. And I know we all know toxic leaders. We probably interact with them in some way every single day, and we have to hold them more accountable, because it's actually killing teams. It's killing organizations, and ultimately there's evidence that it kills patients. In organizations with toxic leadership, there's increased morbidity and mortality rates for patient care as well. So I think we just need to hold leaders as accountable as we would pressure ulcer numbers and central line infections. We really harp on that kind of stuff, but there's toxic leadership can actually have the same impact to our patient care and our teams as those things as well. And we have to kind of get over our opinions as well. So while innovation can start with some ideas that might be opinion, we back them up with fact. Remember, on the evidence-based hierarchy of information quality, where randomized, double-blinded controlled trials are the top of the pyramid, the bottom of the pyramid, the lowest form of evidence, is someone's opinion. Yet we spend 8-hour days with Post-it notes getting a lot of people's opinions on them. And so we just have to think about, how do we better evidence our innovation efforts moving forward, and maybe stop with the opinions. And it's not easy. It's definitely hard work. And eventually you're doing what you're doing, a culture change. And so all the things we talked about, all those patterns, they're artifacts of culture change moving forward. And if you can change those artifacts, which are the physical representations of the way people interact in your system, eventually you'll change their values and then their deep assumptions. So this is work by Edgar Schein out of Stanford. And artifacts are simple things. We talked about some of them. You can get a high-performing team simply by changing the way you talk to them, by changing the room setup from a classroom style to a more collaborative round style, to setting people up and allowing for ideation sessions that lead to small changes. All of those are small artifacts you could do tomorrow that eventually will help people value change and innovation mindset, adaptability, and then it eventually over a few years will become the way you do business, which is exactly what healthcare needs moving forward. And eventually we'll be able to move from the fragmented efforts to the connected innovation efforts. And that's really the dream, is how do we move from the fractures in the arm, the cracks in the system, to a connected technology enabled system where we get along with our patients and our teams in a high performing manner with using evidence-based innovation. And ultimately, it's just starting with one. It's modify one team, create one new partnership, learn one new technology, worry about one less laggard. If you want to know what a laggard is, it's diffusion of innovation, the Rogers S-curve of innovation. It's that last 16% of people that will never adopt a change that we spend about 90% of our time trying to convince. If you go on Wikipedia, and I cited Wikipedia, there's a great definition. If you just Wikipedia diffusion of innovation, scroll down to the definition of a laggard. Great definition and description of a laggard. And I'm sure you know some. And so watch out for the laggards. They suck up your time, and there's only about 16% of them, but they tend to be a large voice. So worry about one less laggard and just do one thing. It takes one step to move it forward. Coming to the conference today is one. Going to the design thinking workshop yesterday was one. And we can eventually create the massive healthcare change out of the disruption that we've experienced over the last year. So with that, I appreciate it. I'll take some questions, and then if you want, I'll stick around and we can chat one-on-one in the Zoom in a little bit. Thank you.
Great, fantastic, Dan. And if Jason could put up the questions, we have a lot of questions in the Q&A, so I think you're going to have plenty of time to address some of these. So the first question I see on my screen is, looking into your crystal ball, what do you see happening to health systems that do not innovate, given the increasing competition from non-traditional entities?
Yeah, I mean, I think they're going to eventually go away or get absorbed into something else. And so, Amazon and Amazon's not afraid to buy stuff. And so if they see a system that's struggling, they may purchase it and turn it into their own, or they may let it kind of die off and see what's happening. So I think we if you're in a system that's struggling to innovate, we have to make rapid change, because there's players that are doing it, both in the system, both in the healthcare system, incumbents, as well as now outside disruptors. And so there's no option not to change moving forward. And we're already seeing hospitals close, CEOs resign. We're seeing some of those patterns that may show us that systems are struggling. And I think there's an opportunity to right the ship. I don't think it's a kind of a tombstone if you're not innovative, but it is a call to action to say you got to adapt, or you're going to get taken over. And the market's right at a point where disruption is happening, and you got to be with it, or you're going to go away.
So your vision for using Amazon for healthcare data is interesting but scary. I don't think most people would trust Jeff Bezos with their health information. What are the unintended consequences of leveraging companies like Amazon, Google, Apple, etc.?
Yeah, I mean, it's a good point. I was thinking about this the other day. My wife works in claims for a large healthcare system, and if people knew how many people actually have access to your health data now, I think they wouldn't trust their own health systems with their data. And so I think there's opportunity there. Amazon already knows everything about you if you use them, and so does Google. I mean, if you look at the data Google keeps on you, they know enough, and so it's already out there. I think we have to continue to drive the security side of things, and probably some potentially regulation or safety pieces around how they use that data to sell things or sell to people. But I think ultimately it's already out there. And if it can provide me a service that's much more valuable, cheaper, quality, cost effective, quality is high, people will trade data for that. And so I think we have to keep an eye on it and make sure that we're doing it safely. But I think there's enough drive if the actual impact to their outcomes is there, that people will trade that for the service.
So the next question is, does this disruption lose the relationship with a primary care practitioner?
I don't think so. I actually think the primary care practitioner could potentially be the hub of everything for this. There's an opportunity to continue to build that relationship and then add on services. There needs to be a coordinator for sure. Patients we know can't have trouble navigating through the complex system. I think the primary care provider provides that navigation and that touch point of connecting all this data together. Now, the problem with primary care at the moment is it's a piece of the fragmented system, and so you're getting bombarded with data and information in ways that you don't have a dashboard for this stuff. So when the patient goes and gets massage or acupuncture, you don't see that data come in. When the patient's doing a wearable, you don't see that data come in. And so if we could create a platform that allows you to have that integrated data and insights in a way that makes sense for your clinical decision making, I think it gives primary care actually a superpower to build a better relationship and actually use all of this information to better manage that patient's care moving forward. I don't think it's a relationship thing. I think there's the video and all these different kind of technology distance tools are part of the tool set, but that relationship in healthcare is the crux of how it's delivered, and I don't see that going away anytime soon.
So this is an interesting twist on the data question. With patient ownership of data, do you see patients being able to then sell, lease, or otherwise extract value from this ownership?
Yeah, that's a great question. I think so. I mean, I still struggle, and I know there's probably information out there why health information is so valuable out in like the black market. I don't get it. Like, if I have diabetes, who cares or whatever. So, but I think so. I mean, patients could sell it. They could sell it to organizations to do research. I mean, I think there's a really interesting opportunity. I was thinking a bit more of health systems now say, hey, you're part of our system. We have your data. This is the Kaiser model, right? Kaiser says, hey, be part of Kaiser. We know you from birth to death. That's a special sauce of ours. If the patient now owns their data and can port it around easily to anywhere they want to go, it disrupts that special sauce. And so it's a kind of an impetus for us to rethink that patient engagement, patient relationship kind of value equation, to say maybe now we have to move to a better service, not just holding them because we have the data that others don't.
Great. How about this twist? Would servant leadership improve innovation on a team?
Yeah, I mean, there's all kinds of flavors of leadership. Servant leadership is one of them. Transformational leadership. What's been proven not to work is transactional leadership. So that's the carrot and stick sort of leadership, and so that doesn't lead to innovation. That leads to status quo and production, sort of industrial revolution mindset, making widgets. So we know that doesn't work. Transformational leadership, servant leadership is a piece of that. Those are all ways to empower like decision making in where the problem is occurring, rather than housing it within the leader. So servant leadership is definitely one tool in the tool belt. The way I think about it is from a complexity leadership theory, which I really like, which kind of incorporates lots of different things, but ultimately it just describes the ability for the leader to kind of give up some of that gatekeeping, and I'm the individual with the knowledge and you're kind of my lowly followers, and turning it into this team dynamic where the leader is facilitating resources and data and information to the team to make the best decisions. Any leadership style that does that is going to lead to better innovation than transactional.
So this is a good one on interprofessional turf wars. So how do you address these turf wars and ongoing regulatory and reimbursement barriers to effect positive change?
Yeah, I mean, the turf wars are that power dynamics between professions, right? And I was just on Twitter earlier today, and I mean, it happens intra-professionally between physician specialties. It happens the same way, like ICU nurses and ER nurses don't get along. So there's definitely there, but I think the problem is in the past we've never educated these professions together. They've always kind of grown up in their silo, and then the first time they get to work together is when they have their first job, either whether it's in residency or attending or whatever it is. And so they've never really understood the foundations of each other's professions, what the scope of practice is, what the value is, or the evidence behind the different ways that people approach patient care. And so we figure it out, and we kind of take this, well, you can't do that, I do that. there's a lot of gray area in overlap of profession, especially between nurse practitioners and physicians, and really every profession has some sort of overlap. So I think we have to address it early on in order to potentially stop those turf wars. And then I would say we need to go back to the idea of that we talked around toxic teams, because sometimes these turf wars turns into toxicity, and it actually is detrimental not only to the team dynamics but to the patient care when we have these turf wars. So I think it's a kind of mix of changing the way we bring teams together and talk about teaming in general, and also really the accountability to be an adaptable leader and not a toxic one.
So going back to concerns about players like Amazon, while they have great opportunities to improve care, local primary care providers are held accountable for the cost and quality of care. I worry that Amazon and others can fragment care even further and could cherry pick the lucrative services.
Yeah, that's 100% true. I mean, if you look at Prime, they cherry pick the best suppliers and things in there too. So, I'm not saying Amazon's going to be some magical bullet to the healthcare system, but they're going to disrupt it and they're going to make us rethink how we do things. And so I think we need to take it that way. Yeah, I mean, it could definitely fragment it. I think. I mean, any of the players, you look at any digital health solution, they further fragment the healthcare system. And even good ones, you think of like Omada Health and some of these other really, really good digital health apps that have shown outcomes in things. They're still housing data by themselves. They don't talk to electronic medical records. Patients still don't, know who's supposed to do what. And so I think all of that is fragmentation. Amazon maybe could pull it together. I mean, they have the ability to buy up some of this stuff and be able to create an integrated sort of network. And maybe they'll open it up through Amazon Web Services, which all of your websites already live on, to allow your practice to, port data across. I don't know. I mean, those are things that we need to push for. And one of my concerns with all of these new entrants is they don't understand the industry as it could be, because it's so nuanced. And so there's going to be a lot of fumbling and failure and stuff that happens with their work. And we have an opportunity to really help shape that and potentially even enhance our practices as things come out.
So in regards to training methods, do you have any comments regarding various types of learners? Some individuals don't do so well with virtual only learning.
Yeah, for sure. So, the med school is not virtual only. It's supposed to be. It is actually in person now. They're back in class, so it's a hybrid piece of that. And I totally agree. So, the piece with education in general is whatever you've set up your curriculum as, you need to interview and admit students that fit that curriculum. And so we spend a lot of time at the med school actually through the interview process and admissions process asking specific pointed questions about teamwork, about group work, about virtual learning, about self-directed learning, so that we could help select the students that fit best with the culture of the curriculum that we created. And so I think we just need to, you have to kind of put the effort in the system. It's not just create this magical thing and then hope people will like it. You have to kind of set up the system from admissions to graduation to meet and mesh with the philosophy you've taken on it. And we have to always think about the virtual piece. I mean, I don't learn well on click through PowerPoints either. But there's an opportunity for us to have multimodal sort of education, whether it's online or virtual or in person sort of hybrid models. I think we have to take that all into account.
We have a question about the reference that you cited. What is the title publisher of the book with your chapter 13 about innovation killers, toxic leaders, and teams?
Yeah, if I have it up on the slide if you want to show it really quick, Jason. It's called Leadership for Evidence-Based Innovation. It's second edition, and it's Jones and Bartlett is the publisher. And yeah, the toxic leadership one is chapter 13, and then we have stuff around the disruptions in technology as well. But you can check it out. There's the cover. It's on Amazon. It's on Jones and Bartlett. But yeah, it's kind of a fun reference. And chapter 13 was my favorite chapter to write. So.
And we've all experienced toxic leadership.
Yes, we all
so sure.
And we talk about what to do with it. I think that's the other piece is it's, let's identify it, but then what do you do about it? So we have some tactics in there about how you deal with it and maybe manage through it.
So the next question is a variation on the PCP question. But it seems like a hyper-flexible workforce means patients don't have a continuous relationship with anyone. If they're looking for continuity, it needs to be a brand like Amazon.
Yeah, I mean that's kind of that's the downside, right? So the hyper flexible workforce, and this is actually a concern as I see this on-demand kind of Uberization of clinical talent. That's something that we need to figure out, because there is evidence between continuity of care and patient outcomes. And so if you have a new practitioner every 4 or 6 hours, potentially, then you have so many transitions in care, things can be dropped. There's no continuity or understanding or relationship building, and so those are things that we need to figure out. And then I think about other industries that have kind of done this, like Amazon, who knows you, who can recommend things based on your preferences, and you don't ever talk to a person in Amazon, but Amazon itself, the platform, kind of knows who you are. Banks are the same way. You call the bank, you don't get the same banker anymore, but they can pull up your record and know instantly all your transactions and maybe some things there. So not that those are the greatest examples, but I think we can look at platforms in healthcare that allow us to better build quick relationships with patients rather than relying on the person. And not to say that person relationships should go away, but in several health systems, the front door to that health system is the highest paid person in that health system, which is usually or clinician in the system, which is usually a physician. And so if think of other business models, if the only way to get into that business is to buy the highest value thing, you're not going to have a lot of people continue to go to it. And so how do we rethink teams and flexibility and who people interact with, so that we're optimizing the system for what those patients need, and then back it up with a platform that allows you to build those relationships quickly and not drop that nuance of who those people are.
Right, see if you actually know this off the top of your head. Can you please share the study title by Dr. Melnick regarding barriers and nurse managers?
That's a great, I don't know the exact title. I'll find it and I'll see if I can send it to Kathy to send out. But it is literally like identifying barriers in evidence-based practice adoption. It came out in 2020, and Bern Melnick was, I can't remember if she's the first author or the second author. But it's definitely out there if you go on Google Scholar. I'll see if I can find the link.
And I will get it out into a document in this session, if you get that to me. Can you comment for potential roles of healthcare workers who left the workforce pre-pandemic in the context of the described fragmentation, flexibility, learning opportunities? Where might there be opportunities for re-entry into a new system?
Yeah, I mean, well, right now there's thousands of vaccine jobs available. So there's a great reentry to the positive side of the pandemic to get shots in arms. And so, at Trusted Health, we have a platform that matches nurses with jobs all over the country, and we're seeing a big uptick in vaccination roles. Also in ambulatory care, and so that's another place where we're seeing a lot of uptick in at least clinical nursing, clinical talent. So those, I think, are two big ones. But then I would also look, I mean, honestly, Apple's hiring nurses, Google's hiring nurses, Amazon's hiring nurses, Salesforce is hiring nurses. Like, there's opportunity in the tech sector to actually come in and help shape the future. And I think that's a really interesting way to, and physicians and physical therapists and all. And I'm sorry, I always think nursing first because that's my background. But they're hiring clinical talent into those tech organizations. So if you're afraid that they're going to take the data and blah blah blah, maybe it's there's an opportunity to actually join and shape it with them and make it come out the right way too.
So glad you mentioned interprofessional education. It's so needed. Early in the pandemic, it closed outpatient centers, left thousands of professionals sitting on the sidelines. Why don't we have a plan to use our trained workforce in these emergencies?
I wish we knew the answer to that, because we saw exactly the same thing. Now, there were some hospitals that actually did it, and this was localized. So like New York Presbyterian, they took operating room nurses as the ORs closed and put them in ICUs to help out in ICUs. So that was kind of a quick shift, and they were able to take different clinical talent and put them in places where they were most needed. But we totally missed out on new graduate nurses with 1 or 2 years of experience that may not qualify for those high-level ICU jobs, but have competence in something and could potentially free up more experienced clinicians to do the COVID related work or higher acuity work. Same with medical students. And it goes back to my point is there's no single source of there's no single system of record for the healthcare workforce. We just don't know where any given clinician is at any given moment and what they're doing and what their competence is. And so we're kind of throwing darts at a wall, and it's not great. So I think the solution really is to have better workforce data and then be able to match that workforce skill, intent, passion, clinical drive to jobs and ultimately patient care out there. And until that happens, we're still going to be very clunky in how we move clinical talent across the system.
So as we speed up with this disruption, how do we protect data? Cybersecurity protection has great ambitions, but continues to fail.
Yeah, I mean, it's the trade-off piece. I'm not a cybersecurity expert. I'm sure there's lots here, but there's I've seen startups now that are very focused on this, on the cybersecurity side of things. But yeah, I mean, I think we just have to continue to stay vigilant on it, and not just open up the floodgates of data to everybody. But we also can't use it as an excuse to stay where we are because others will move forward. So we got to strike the balance.
So the comment is, I 100% agree with using the personal device as a resource. What is industry's reaction or labor's concern over using that at the employee's expense? Anyone sharing stipends towards smartphones like parking or travel expenses? Or do we treat this like the stethoscope or scissors that the nurse supplies?
Yeah, I mean, there isn't like a good national model that I've seen. For the most part, what I've seen, at least for the staff side of things, is that the hospital system buys the devices and supplies them on the units. And so you come in and you just like having your badge, right? You just pick it up out of your charger and it's yours for the day, and you put it back in the charger at the end of the day. And so there's no cost involved from the clinical standpoint. On the physician side, I've seen it both ways, where there's a stipend, monthly stipend for paying for the phone because they're using their own, or BYOD or whatever. And so I think it's just really, it just depends on your context. Now, I came from Kaiser Permanente, which is heavily unionized, and labor made sure that the health system paid for and supplied the devices. But in other systems that may not need to be true, and you can do a certain monthly stipend related to it. I think ultimately it's going to be like it should be like the stethoscope. We didn't talk about it, but eventually maybe the stethoscope goes away. You don't need that anymore, and you use handheld ultrasound machines that attach to your phone to do most of your assessment. So I think those are the type of things we need to think about. Is digital health tools are going to continue to be adopted and get better and better, cheaper, smaller, and they're going to be part of your tool belt. And so I think we need to really think about a strategy of how do we enable our clinicians with those technologies so they can be really amazing, superpower clinicians.
So do PCPs need to have a relationship with Amazon in your vision?
Sure. I mean, why not? You already buy, your food and stuff from them. So, I mean, I think ultimately it just depends. It depends what Amazon's going to do. Right now, Amazon's doing virtual care, and if they're doing virtual care and you have patients that are seeing them, you need to have a relationship in some way just to get the data from that visit into your clinical decision making. So at some level, it's going to be driven by your panel. If your patients are seeing them, you're probably going to have to talk to them at some point. But I think ultimately we'll see where it goes. I mean, Walmart also had big ambitions to build 1 billion clinics, and they've kind of scaled that back. We'll see. Amazon's not afraid to jump out and then stop things. You saw that with their open your garage tool. They were very excited about, or deliver your packages to your trunk of your car, and did a lot of advertising around that. And then they pulled that back really quickly. So, they may be on a fail fast side, but if it sticks and your patients are going, yeah, you're going to have to make a relationship there.
So what healthcare policy changes do we need to advocate for so we can keep up? Do you envision healthcare systems being penalized for not offering telehealth options?
Yeah, I mean, I think there's a greenfield there, and we saw some of so the thing near and dear to my heart is licensure regulation. So the state-by-state licensure just doesn't make sense. It doesn't make sense in a pandemic. It didn't make sense before. It's a very money-driven, archaic system based on paper and crappy process. And so I think, to enable us to deliver care as a system, we need to get rid of state-by-state licensure. And that could even open the door to workforce data that would be more accurate. So it's not housed in these licensing boards in silos and in paper files in their cabinets in the state house. So I think that's the number one thing that would actually open up a lot of opportunity for us to do different things. I think the reimbursement around telehealth obviously needs some help and fire under it, and we're starting to see that with the CMS Medicare stuff. And I think eventually, if it's a service that improves outcomes, then health systems, just like they do now, value-based healthcare system, if you're not adopting things that are proven to improve patients' lives, then you either get less reimbursement or penalized for not adopting it, similar to medical record. So I think that's an incentive, and what that does is it sweeps up the laggards. So you can get by a long time doing what was always done if you can get reimbursed for it. But eventually, if they don't get reimbursed for it anymore, it's going to change behavior. And so right now in our system, that tends to drive a lot of behavior because we're slow to change in healthcare. So I think we do need to change some policies there.
So regarding the workforce data you were just mentioning, what recommendations might you have about what specific data would be more helpful?
Yeah, I mean, I think right now so I'll use nursing as the example, and I don't know how the physician side of things works, so I definitely need to learn there. But the workforce data for nursing happens in most states every 2 years when you renew your license. And so when I renew my license, I just renewed it in Arizona, I get put on a survey monkey after I pay my fee. And I have to answer like 60 questions about when I plan to retire and what I'm doing right now and my salary and all these different things. And about 20% of nurses fill that survey out. It's not mandatory, except I think in Michigan. And so that 20% of all nurses who happen to be on a license renewal year, now that's our workforce data for the whole state for nursing. And so it's just not a representative sample. And none of that survey asked me about what certifications I have, or ask me like, what degree I have, but it doesn't ask me my certifications or what units I work on or what hospital, or it doesn't ask any of this data that actually could help understand your clinical expertise, competence, skill set. And eventually, if we could have a system of record that has a clinician's expertise, what technologies they're competent in, their certifications, their even kind of samples of the types of patients they've had, then you can understand the clinical talent within a geographic area. And when things happen, whether it's a surge or a crisis or a natural disaster or whatever it is, you're able to tap into that talent and quickly engage with them to move them to where they're needed, rather than just saying, hey, you know what, 20% of the 50% of nurses that now are renewing this year kind of filled out the survey and didn't really give us valid data. I think there's just a big opportunity there. Think of a LinkedIn for clinicians. I mean, that's really what we need.
So we're seeing AI creeping into the medical profession, such as in radiology. Do you see how it may innovate nursing?
Yeah, I mean, it's already innovating nursing. I think, we talked about the advanced alert monitoring system. That's data that goes directly to nurses. That's the sepsis and the kind of early demise, rapid response sort of things. And so more and more of that's going to come in, I think. But like I said, the clinicians working right now haven't been trained in how to assess and take in that augmented, intelligence and put it as part of their clinical decision making. So I think we have to change the way we train clinicians so that they know what it is. And I think moving forward, it's going to provide insights that what nursing likes to call intuition, or that gut feeling with things. It's going to actually validate that with data. And so now we'll have the gut feeling and data to move on different interventions. And I think that's really exciting.
I think we have time for one more question. So could you comment on the impact of adherence to treatment or poor adherence with future innovations?
Yeah, I mean, that's one of those like really hard, audacious problems that no one's solved yet. So I don't know. I don't know what the answer is. I think the more you make it easy and embedded in someone's normal routine of life, the more it's going to be adopted. And that's just kind of the science of innovation and change. And so if it adds value to them and it's part of their daily life, it's going to be much easier than them having to, go to a clinic and wait in line, and, the clinician's 28 minutes late and blah, 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 blah. And so I think there's an opportunity that technology can help just make it a routine that's easy and eventually get adherence. But, we've tried it with pill packs. We've tried it with, reminders and alarms and, robots and all this other stuff. And it still hasn't got us great adoption. It's similar to the hand washing dilemma. Like, we can put people literally hitting your hand with a ruler when you walk out of a room if you didn't wash your hands, and we still only have 66% compliance. So at some point there's, we're never going to get to 100%, but the more we can make it easy from an adoption standpoint, the faster it'll, or more impact it'll have with patients.
This is fantastic. Thank you, Dan. And we definitely got some great comments in the chat as well about the great perspective. And just want to thank you so much for sharing your wealth of kind of innovation knowledge with us. I want to encourage folks to fill out the session poll or feedback. So down at the bottom of your screen, there's a link to session feedback. If you wouldn't mind doing that, that would be great. And as a reminder, Dan will be available for some more personal Q&A conversation chat in a Zoom room shortly after this session ends. And I'll be putting that in the EventMobi app as well as in the chat box. So thank you again, Dan, for joining us.
Thank you.
If you all want to take a break and either join us in the Zoom room with Dan, or go over to the exhibit hall and visit our exhibitors, or join the virtual yoga session, that would be great. All right, enjoy, and thank you very much for joining us.